There are many changes I would like to make in today's healthcare system. However, the issue that I would like to discuss today is really related to public education. Um, I work in the pediatric ICU, and I see a lot of things in the PICU that could really be avoided with more public education for parents, especially. Um, the thing that I'm really going to focus on today is just more public education related to the need for helmets. Um, Especially now that it's summer, we see numerous kids with traumatic brain injuries who possibly could have been avoided had they been wearing a helmet on whatever activity that they happen to be doing. Around 26,000 bicycle-related brain injuries occur each year, according to the Centers for Disease Control and Prevention, that need to be treated in the ER, and some of those obviously need to be further treated in the ICU. And that's just bicycle related. That doesn't cover like your motorized sports or skating, scooters, those kind of things also. There's some helmet education for public, but I'd really like to see more robust education happening. Things like educating parents which helmets are required for which activity, because the bike helmet is different from skating, and the helmets that you can get that are rated for multiple activities are really few and far between, and most people use one helmet for everything. Clinics could be held to fit helmets and allow people to try on different brands, different sizes, and ones for different activities. Public education really needs to address the consequences of what can be prevented by simply wearing a helmet. Many of the kids, I think most people know that they can be injured, but many of the kids that I see won't walk or talk again, and they end up trached. It's not simply like, oh, they fell and they got a cut and they got some stitches, which I think tends to be what most people think of when they think of helmet-related injuries. A clever ad campaign, such as like the famous Got Milk ad campaigns for bicycle helmets, could also be something that was implemented. And I think both legally and ethically, the program would have to be overseen by experts in the field of traumatic brain injuries and sports-related injuries and prevention. The program would be required to disseminate information that is factually correct, but be cognizant of not saying, like, this helmet's going to prevent all head injuries, because we know that regardless of the type of helmet, there's sometimes just going to be head injuries that occur. And I think legally and ethically also we have to consider what would be the outcomes of a possible law requiring helmet use for everyone and those sorts of things. There are many issues that require further education, but I think that implementing expanded education related to helmets could really be life-changing, especially for the families of some of these kids that I see. They could have really had different outcomes. So now about the changing nursing role in quality patient outcomes and reimbursements. The role of nurses in quality patient outcomes and reimbursement seems to be ever expanding in the current healthcare field. Reimbursement is tied to patient outcomes and quality, as we are aware with things like patient satisfaction surveys. Patients spend most of their time in the hospital with nurses as opposed to other healthcare providers, so tying satisfaction to reimbursement has really put more burden on the nurses to provide care that's going to satisfy patients and to provide good patient outcomes. So the type of nursing care delivery model that you believe will need to be in place by 2020. In the PICU, we currently practice total patient care, and I think that that's really probably the best model for my unit, and I haven't had enough experience on other units to kind of speak to what necessarily works best for them. So we have a tech for my unit, and they'll help with things like turning my patient, or if my patient needs to get up to the bathroom. But as far as like actual assigned patient responsibilities, they don't have those. I get all of my own vitals, I do all of my own baths, those kind of things. This is a model that I feel will continue to be used in the ICU setting even into 2020. The ICU has several differences that make it ideal for this sort of nursing care. In the PICU, we have PICU RT that's in the unit at all times. They are assigned only to our patients. They don't go to see patients on the floor or in the progressive care unit. They are just for PICU patients. We also have 24-hour physician care with a resident and an attending that's always on our unit. So I think that having access to those things in a quick and timely manner, which they don't always get access to on other units, I think lends to better effectiveness of total patient care. And also the nature of the PICU setting is just that we're constantly trending tiny, small changes hour by hour. And I think that the more people you involve and the more people you give responsibility for doing that, just the greater risk of things falling through the crack between providers is. So what type of restructuring activities would your organization will need to be involved in over the next several years to be ready for 2020? So my unit is currently utilizing this model, but we do have some restructuring related to this model currently. It really involves projecting future needs and changes in the unit, such as anticipating people leaving. We have a bunch of people in the NP programs that are graduating, and we have to replace them. It takes a long time to replace them, especially if we're replacing them with new graduate nurses. Our orientation tends to be around 6 months, so it's not a short process by any means. And we're currently in the process. We just opened a pediatric heart program at Kentucky Children's Hospital, and so we're currently in the process of adding 4 beds that are specifically designated for our cardiac ICU patients, and that has really required a lot of restructuring related to staffing, cross-training for those nurses to be allowed to care for them effectively and have great patient outcomes in that program as well. And it also involves restructuring and looking to the future as far as how many cardiac ICU patients are we anticipating to have on a day-to-day basis? How many planned surgeries are we having? How many anticipated admissions will be unplanned for that unit as well? Criteria to use for evaluate effectiveness of nursing care in the organization. So I think patient outcomes should always be used to evaluate the effectiveness of patient care. Things such as mortality rates, expected length of stay versus actual length of stay, any adverse outcomes such as pressure injuries, CLABSIs, CAUTIs, readmission. Those are all trackable with subjective data, and they're directly related to the caliber of nursing care that we provide to our patients. I think that those are always going to be your gold standard for evaluating how effectively you are offering nursing care to these patients. Thank you.